the dentist and the patient and psychological background is very important of the pain, you know, and there are some areas in medicine in which the pain itself is very important. For example, neurology. Of course, in the general branch or the general colleagues who can professionally manage the pain conditions and especially chronic pain conditions, these are neurologists. Okay, so when you have some problem with your patients, so chronic orofacial pain conditions, for example, because the orofacial pains are the most important pain conditions after the low back pain, most frequent, you know, low back pain and headache. Headaches and low back pains, these are the first two most frequent, and after we have the orofacial pain conditions, you know, the intraoral and extraoral pains, temporomandibular joint pains, for example. So these are very important and frequent conditions. You have to understand the physiology and even the clinic and even somehow the psychology of the pain, because the response for the treatment will be reflected on your management, of course. And the pain itself is very important, that it is an emotional experience of the patient. It is a subjective thing, and it can be associated to tissue damage, but sometimes there is no actual tissue damage. So it could be that there is no you know, disorder, real disorder or disease behind the patient pain complaint. So sometimes we have pain conditions without signs, without findings, and without signs, intraoral signs, for example, and no tissue damage of the pain. And as you know, for example, we have a very dangerous and unfortunately relatively frequent condition, the oral neoplastic lesions. And these oral neoplastic lesions, the pain is a late condition, late. It is not an early sign, you know. So we have the very lethal and dangerous disease, but here the most important and symptom, the pain can bring the patient to the dentist or to the specialist to treat the condition at an early phase. But for example, in this very serious disease, the pain condition is not a reliable sign. It is a late condition, unfortunately. But we have some absolutely not life-threatening conditions. For example, burning mouth syndrome. It is very frequent in older patients. Or we have neck sensitivity, you know, tooth neck sensitivity, or dentin pain. In these conditions, the pain is a reliable sign, but these conditions are not life-threatening, so the danger and the tissue problems and the pain condition, these are not associated strictly. And of course, it is a very important symptom, the pain itself, but it could be a disease itself. Okay, so when the pain is a symptom, it is a good thing. The pain is physiologic, because when you damage the tissue, we have an inflammation somewhere, for example in the palm, and this inflammation is manifested in pain response. And the patient knows that there is something wrong with the tooth, let's go to the dentist. So it is a good thing. Physiologic pain, early acute physiologic pain, it is a symptom. But when the pain is not treated perfectly, even in the orofacial region, it can become a pathologic pain condition. You know, pathologic pain, it is a chronic pain, you know, because it is when the pain is not treated and not eliminated in the early phase, after some months, for example, after 4 or 6 months, it can become a chronic pain, and it it will be a disease itself. So the pain from this stage is not a sign, it is not a symptom, but it will be a disease itself, the disease, pain disease, okay? Chronic pain or pain disease. And of course, it can prevent the further tissue damage because it is a good symptom, physiologic pain. And the pain could be without pathologic process, psychological pain, as I mentioned you. But even the patient pain is psychological, you shouldn't question the patient pain suffering, okay? Your patient pain suffering shouldn't be, it is a very important rule, you know, that the dentist or other healthcare specialist shouldn't question the patient pain suffering, because the pain is a subjective symptom. As I mentioned, you only the patient knows what is his or her suffering about the patient pain condition. And you can see here a very frequent pain condition, the neck sensitivity, where the neck, in the neck region, the dentin is free. It is not covered by the enamel, you know, sometimes abrasion, bad brushing technique will initiate this and will propagate or will start the pain itself. So with the blisters, you can, mechanical irritation this pain condition is dentin hypersensitivity. Sensitivity is normal, of course, because we have mechanical sensitivity to the stimulus. Of course, when the stimulus is very high, we have sensitivity. But the pain is not normal, of course, when you brush.
The color is also not normal. It's too pale.
No, it's normal. The color of the gingiva,
but
it is different. I just said to you that when you investigate the patient, you should know that the sensitivity response is normal. It is a normal response. So sometimes when you investigate the pain conditions and the tooth, for example, with decay, you use a stimulus, called a stimulus. And the response, patient response, when the patient responds, the patient says, yes, it is sensitive, it's normal. But when the response is pain, it's abnormal, okay? So,
it's cement to me.
The dentin is a little bit yellowish, more yellowish here. This is the dentin.
How do you treat this?
There are some ways, you know, you can use topical applications of materials, even steroids, or even some bonding agents. You can, or sometimes you can place fillings, or even root canal filling is necessary in some conditions when the patient pain is so severe and you cannot treat other ways, okay? But usually in the first stage, you should suggest the patient, you know, anti-sensitive toothpaste, you know, the Sensodyne is the most well-known, yes. So it is a special topic. We don't need to discuss this. And the pain in the clinical condition, in the clinical practice, you can investigate the pain, of course, with the anamnesis is important, asking the pain conditions in the anamnesis, but in the investigation, you propagate or you stimuli with different stimulus, you initiate pain, so the pain and sensitivity. Some sensitivity is normal, as I mentioned you, but sometimes when you have inflammation inside, the pain is the response. So during the physical examination, you deal with pain, or we have different stimulus called an electrical stimulus during the physical examination, and of course during the patient treatment you manage the pain. So I just want to emphasize that from the anamnesis until the patient management or treatment or care is finished, you can find or manage or treat the pain, okay? Pain, because it's a very important condition during the whole length of the patient treatment. And you have to differentiate between pain and nociception. Okay, pain and nociception. Simply, the nociception is the physiological background of the pain. Neural processes and peripheral and central neuroanatomical things behind the pain. So, and the pain is an emotional experience, and it is very characteristic to human being. Okay, so of course, even an animal, an experimental animal, can produce nociception, and you can investigate as a scientist in an experimental animal the nociception. But the pain is treated only in the clinical practice, okay? So it is different because the pain is always subjective, and there is behind the nociception, there is the whole human being with the psychological background. And so the basis of the nociception is the peripheral function, the nociceptor functions. So they will, the peripheral, they say sometimes nociceptors, or it is not a good term, but pain receptors, you know. They say pain receptors, but it is not good, but we understand this. Pain receptors are so-called free nerve endings at the periphery. Free nerve endings, but the proper term is nociceptors. So the nociceptors can respond to the stimuli, the peripheral stimuli, and of course the action potential is propagating toward the central nervous system. And there is some modification along this way, you know, toward the, and you can apply noxious or painful heat or cold or pressure or chemical, or as I mentioned, you sometimes electrical stimulus can be used to initiate pain, or to investigate the pain or sensitivity. Pain or sensitivity, this is the question when you investigate. Can you feel pain or sensitivity? And when the answer is usually sensitivity, it's normal. When the answer of the patient is pain, it's usually abnormal. Okay, so this is your question. When you apply heat, cold, intensive, or big pressure to the questioning or investigated teeth or area. Sometimes the anatomical structures, temporomandibular muscles with pressures, okay, are investigated. And you know, the behind the pain, that is the nociception and the sensory nerve function behind but the most important sensory nerve, of course, in the orofacial area and the oral cavity is the trigeminal nerve and the upper cervical ganglions supplying the palm tissue, and these are responsible for the dentinal and pulpal pain conditions. You know, they enter into the pulp and the cavity, the tooth cavity, through the apical foramen, and in the root pulp we have few branches only, but a lot of branches, up to 80 branches per nerve fiber. We have in the pulp chamber, and we have the Dashkov plexus. The Dashkov plexus under the odontoblastic layer. These are unmyelinated send unmyelinated, this Rashkov plexus will send unmyelinated fibers toward the dentin and into the predentin and the dentin. We have sometimes inside the tuberous fibers inside. And there is a gap junction between the odontoblasts and the free nerve endings, but no synapses, okay? Synapses are contacts between two neural cells, neurons, between two neurons, but between the neuron element, you know, or free nerve ending, and the odontoblasts, we haven't discovered until now this synapses. But gap junction, we have gap junction. So it is very important when you would like to explain the patient dentinal pain, why the dentin is sensitive.
Where are the gap junctions? Between what and what? The gap
Between
junctions.
the free nerve endings
Okay. In the
and
palp?
the body, periphery of the palp, and the body of the odontoblasts.
Okay.
Odontoblasts,
Yes, of course.
periphery of the palp. Yes. So gap junctions, but it is important but because the scientists tried to explain the dentin sensitivity, and they have found real connections, and they said even the odontoblasts can perceive the pain, okay? Even the odontoblasts would be the first element in the periphery which perceive the pain, but the problem is that there are no real synapses between odontoblasts, nature, and the free nerve endings. So these explanations for the dentin sensitivity is not true, is not valid, okay? Because not true because we have only gap junctions. So the gap junctions couldn't be synaptic function, couldn't perform synaptic function, okay? And this is why it is important. So the function of the gap junctions could be regulatory. So these nerve endings can regulate the odontoblastic functions somehow. For example, they may activate the odontoblastic dentin production. So they may reactivate the odontoblasts. But these elements are not active in pain perception, okay? So, of course, we have the peripheral free nerve endings, and the cell bodies are located in the trigeminal ganglion, Gasserian nucleus, okay? Trigeminal nucleus, peripheral nucleus. And you can see here the central pathway of the pain propagation, central pathway, and we have the first neuron, the first peripheral neuron, represented by the branch of the trigeminal nerve, and we have the sensory nucleus, as I mentioned you, this is the Gasserian nucleus, and the second order neuron will transmit the impulse toward the thalamus, and the final stage and for the responsible for the localization and for the response, pain response, for example, motion or other response will be in the sensory cortex, okay, in the sensory cortex. And the reticular formation from the subcortical centers to the thalamus, there is the reticular formation through which the second order neurons are transmitting the impulse toward the thalamus. But in this reticular formation, this pain condition may be changed somehow. So some modification may occur in the reticular formation. You know, sometimes maybe you know about the depraved pain perceptivity of the soldiers. Maybe the soldiers have deep wounds, but you know the psychological status of the soldier is so high that the pain stimulus threshold is very, very high. So, and it is explained by the inhibitory function of the in the reticular formation. So in the reticular formation, there are inhibitory cells acting to increase the patient pain tolerance. Okay, the patient pain tolerance is increased on the soldiers, but sometimes you should know this in the clinical practice. You know, for example, we have when you have a very good, nice music in the background in your surgery, in your dental surgery, it could be good for the patient pain tolerance, for example, because there is a psychological pain killing or psychological pain modification method. You know, and we have in the thalamus, we have thalamocortical connection, and in the final side, in the cortex, the intensity and the localization of the pain is occurring. And we have two main areas of the thalamus in which the emotional and the nociceptive component of the pain is managed. Posteroventral nucleus and dorsomedial nucleus or center of the thalamus, you know, of the thalamus. And the patient pain memory is stored in the thalamus, you know, because your patient and especially the children will remember, of course, your treatment in the future, and this may affect the whole relationship to the dental service. Okay, so and this patient memory storing phenomenon is different in men, in women, for example, and even in children, as I mentioned you. But sometimes the children, parents, triggering the children or worsening the children response to the so-called painful dental interventions. When a child, when you tell to a child that this condition was painful or will be painful, it will be painful.
Yeah.
So you shouldn't do this, of course. You should do everything with to prevent this. So the patient and the circumstances should be calm in the surgery, and it is very important. So you can see here centers in the medullary and in the medulla, you know, in the medulla, and this is the primary area where the pain is transmitted from first ordered peripheral neurons to second ordered peripheral neurons is the spinal nucleus of the trigeminal nerve. Okay, spinal nucleus. It is a long nucleus in the medulla. Even in the spinal cord, we can find the most distal part, this spinal nucleus. So in the pain management or response, this subcortical area is the most important, the spinal nucleus of the trigeminal nerve. We have three main areas, three main subnucleus, of this nucleus: the subnucleus oralis, interpolaris, and caudalis. These are the Latin names: subnucleus oralis, interpolaris, and caudalis. And these are responsible, these subnuclei are responsible for the afferent sensations of the orofacial structures. Of course, we can tactile stimuli and mechanical and other osmotic stimuli. This nucleus is responsible, but for the pain, the caudalis is the most important. Okay, so the caudalis is the most important subnucleus, and there is a crossing toward the thalamus. And as I mentioned you, there is the reticular formation. You can see here the second order neuron toward the reticular, through the reticular formation, and you have here some inhibitory and excitatory responses or effects in the reticular formation. So from here to the thalamus and midway, we may experience some inhibitory or excitatory neural functions to lowering the threshold of the pain or increasing the threshold of the pain. Okay, it is very important, and you have here the thalamus and the two main parts, the nucleus posteroventalis and dorsomedialis nucleus of the thalamus. We have these two main parts, and this is the subcortical center where the pain is stored, and even vegetative response is initiated from the thalamus to the hypothalamus, So that is when you have hormonal reaction or vessel reaction, for example, flushing, the blood flow is increasing, the heart rate is increasing. So this is the acute pain response, the adrenaline or the, when you have stress situation, pain is a stress, of course, and you will see the stress responses. His heart beating is increased, and blood flow is increasing, and of course the hormones, ACTH, for example, is increasing as well. So in the hypothalamus, and we have modulation. As I mentioned you, it is very important. We have peripheral factors. You should know that after sun burning, for example, your skin is inflamed a little bit, and it is very sensitive because histamine or other molecules will accumulating there, which increase the patient pain response. Okay, so when these molecules, potassium, for example, so when you have tissue damage, the potassium will pouring from the cells to the extracellular area, and they will irritate the free nerve endings. Okay, the free nerve endings, and the response will be higher pain sensitivity. So when you have cell damage, from the cell damage, you have these molecules which pouring into the tissues, and the sensitivity of the free nerve endings is lowered by these factors. So we have molecules, pain mediators, peripheral molecules, histamine, serotonin, or type hydroxytryptamine and potassium and polypeptides. We have the so-called polypeptides, for example, the pain inducing polypeptide and prostaglandins, and we have the neural cell or fiber intervention, because when you have the A beta fiber activity is high, when your A beta fiber activity is high, the A beta fibers will be responsible or are responsible for low, non-painful mechanical stimuli. So when you have a massage, for example, gentle, pleasant massage, so it is not painful, of course. So when you have this massage, for example, it can reduce your pain, because it is said that we have the pain gate theory, the gate theory of the pain, and when the A beta fiber activity is increased, these A beta fibers will, we reduce the patient, and inhibitory responses will be initiated in the as you know, the reticular formation. So in the reticular formation, we have inhibitory fiber activity because of this TENS is a transcutaneous electrical nerve stimulation. It is used in the neurology, but in orofacial pain conditions, it is like a massage, electrical massage, okay? Not mechanical, but electrical, transcutaneous electrical nerve stimulation. So the nerves which are not responsible for pain perception, but other afferent nerves are triggered or by this electrical equipment, okay? And massage, acupuncture may have increase the activity of the A beta fibers, and the response will be low patient pain perception. And we have the central modulation, the reticular formation, and we have some endogenous opiates, for example, when you have very pleasant condition, or even when you do exercises, these endogenous opiates concentration is increased, and the patient and the pain is reduced. And we have the placebo effect. This is very important in the clinical practice. Even you can use 40% placebo effect. What does it mean? The placebo means that when you have a good personal relationship, a trustful relationship between the dentist and the patient will believe that you will manage his or her pain condition, and this is the placebo effect. So when you have this relationship, you will gain because the placebo effect is working, and it is a very important pain killer. The placebo, you should use this placebo effect in the clinical practice. Okay, normally, okay, but you shouldn't use this non-ethically, of course. So we have pain mediators and pain sensitizing agents here, and you can see here the mediators, sensitizing agents, the mediators. But these molecules are increasing the pain, okay? These molecules. But the science can differentiate between mediators and sensitizing agents. Sensitizing agents means when you have, for example, tissue damage, as I mentioned you, the peripheral free nerve endings will be will be triggered to firing by the peripheral molecules. So in this sensitizing agents means that the threshold of the free nerve endings is lowered by these agents, by these molecules. And we have mediators which can affect generally. So it is not just peripheral, but it is a general effect. For example, we have the prostaglandins, and the prostaglandin general effect. So the whole body will be affected. And substance P, as I mentioned you, is a very important polypeptide, can affect the patient pain, suffering, and tolerance. And you have different pain conditions in the dental practice. We have acute and sharp pain condition, and dull pain condition, and non-localized pain condition done. So for the acute and sharp pain conditions, the myelinated A delta fibers are responsible. So fibers responsible for pain transmissions, these are A delta fibers and C fibers, okay? C fibers of the neurons, and A delta fibers are responsible, myelinated fibers are responsible for the well localized sharp pain. So when the patient pain is well localized and sharp, the neural element behind this is the A delta fibers, but C fibers are behind the dull pain condition. For example, when you have, palpitis is after some time, palpitis is a dull pain condition, and unmyelinated C fibers are responsible. But when you have neck sensitivity, the primary response is based on the A delta fiber activity. And in the clinical practice, you may experience with the poor patient pain localization and irradiation of the pain condition. Sometimes the patient will not differentiate between the upper teeth pain and the lower teeth pain, because these peripheral nerve elements ended at the same central neural element. Okay, so the center is the same, and the patient at the periphery will not know which tooth is responsible for the pain, because the pain for the patient condition, because the pain is irradiating, and sometimes it is localized poorly, because the central element could be the same, the central cell, and this is the reason, and that's why it is so important to apply stimuli in a proper way to differentiate between the palpal pain and temporomandibular pain and muscle pain, because of this phenomenon, of this convergence of the peripheral nerve elements to the same central cell. And I just partly I emphasized that we have different fibers in the pulp tissue. In the pulp tissue we have A delta fibers, afferent fibers, and we have C fibers. And we have other elements, A beta fibers, the other fibers, but these A beta fibers are regulated A delta fibers are responsible for the well-localized dentinal, for example, pain. When you drill the tooth, for example, the A delta activity is increased immediately, and when you apply cold to intense cold or warm stimulation to the tooth, the A delta fibers are activated, but in after some irradiation and when the pain condition is propagating, for example in pulpitis, in ulcer pain, the C fibers will be the responsible for the patient pain response. And when you experience neck sensitivity, you will feel the pain in two phases. First, the A delta fibers are active, and you will feel this pain condition as a localized, but immediately after, in 2 minutes, you will feel dull and irradiating, non-localized pain because the C fiber velocity, so propagation of the action potential in the C fibers is slower than in the A beta fibers. So the A beta fibers transmit more fastly the pain stimulus into the center than the C fibers. So this is the reason because you feel the pain in two different phases. First, it will be localized and sharp. After, it will be poorly localized and dull, the pain, when you have this neck sensitivity. Maybe you know this from neck sensitivity, when you personally have this.
So alpha beta is the fastest, then alpha delta, then C.
Yes. So it depends on the diameter and the myelinating. When it is myelinated, it is faster. When the diameter is larger, it is faster. The propagation. Yes. But these are alpha fibers are not afferent but efferent fibers. Okay, efferent.
All of this is efferent, right?
These are afferent fibers, afferent toward the central.
Yeah.
Toward the central. Efferent effectors, efferent toward the periphery. Okay. For example, toward the muscles, efferent fibers. So it is a different topic. We don't